Sounds good, but parking's better. Okay, well, thanks very much. Thanks for the invitation. So what I'm going to be doing, and so time-wise, we've got about 40 minutes, is that right, Barb? Yeah. 45 minutes? Okay. So I'll be focusing on vaccine-preventable illness in the elderly. So basically, it's, in a short period of time, it's hard to give a lot of tons and tons of information, but I'll just highlight what I think are the most important challenges in the elderly, just looking at the epidemiology of particularly pathogens that are very common, like influenza and pneumococcus, a little bit about their epidemiology, about why they're so important, why they're such important causes of morbidity and mortality in the elderly, and I'll also focus on more or less recent updates, recommendations on immunization for older adults. So I'll start off with a sort of case scenario, and this was actually a real case we saw at McMaster. This was a 76-year-old who had presented with a history really of symptoms of respiratory infection. His background was he was a retired truck driver. He presented with shortness of breath, cough, yellowish sputum production for about a week, and he really was getting worse, progressive worsening, and he presented because the shortness of breath was becoming too much for him to bear. He had a pretty complicated past medical history. He had interstitial lung disease, and there was a question about whether that was due to exposure to asbestos in the past. He was a diabetic, ex-smoker, but had a pretty substantial history of smoking and a history of heart failure. And when we saw him, we don't really know whether he had received the pneumococcal vaccine, but he was pretty sure that he never got the flu shot. A CT scan of the chest that had been done previously showed reticular nodular changes at his bases, compatible with this interstitial lung disease picture that he had. On physical exam, he was alert, but he looked really unwell, diaphoretic, tachycardic, tachypnic. His blood pressure was low, afebrile. Reduced airway at the bases and really wheezy at the bases. Cardiovascular exam was unremarkable. Abdominal exam was normal. Skin and neurological exam was okay. This was a chest x-ray, and as you can see, right upper lobe pneumonia. And so we're left with a diagnosis of community-acquired pneumonia, right, which is defined by pneumonia acquired in the community, and it's a constellation of clinical signs that he met: shortness of breath, purulent sputum production, and radiological confirmation. So one question is, what are the risk factors for community-acquired pneumonia in the elderly? And this is a nice study that was from Finland, where they decided to actually look at community-acquired pneumonia in an entire township. So they followed this whole town prospectively. They did x-rays on everybody, and they were particularly interested in looking for risk factors for the elderly. And they found alcoholism, history of asthma, lung disease, and heart disease and age as important risk factors. So our patient here had several of these. He had a history of lung disease, heart disease, and his age increased his risk. So just a few facts about community-acquired pneumonia. It's as I mentioned, it's pneumonia that's contracted in the community rather than the hospital, and it's defined by clinical characteristics with radiologic confirmation. And the attack rate really affects people at the extremes of age. So, very young children are at higher risk, and with age, after the age of 60, it tends to go up. And as you can see here, over the age of 70, it goes up with 50 cases per 1,000. So it's one of those infections. And a lot of infectious diseases, you see that. We see an increase. We see extremes, in the very young and the very old, and we see more complications and deaths in the elderly. So in terms of continuing this case scenario, he had a high white blood count. He was in marked renal failure. He was hypoxic. He was just really going down the tubes, so he had to be transferred to the intensive care unit. And he was treated empirically with antibiotics, and we happened to do a nasopharyngeal swab that was positive by PCR for influenza. And blood cultures grew Streptococcus pneumonia, as you could see over here. So this is the characteristic morphology in a blood culture of pneumococcus. So just a sort of important take-home message before we get into all of the prevention and the vaccine stuff. So just presented a case of community-acquired pneumonia. It's important for you as geriatricians to know what the most important etiologies are, and really the take-home message is that for outpatient or inpatient for that matter, pneumococcus is by far the most important pathogen. Okay, you can also get as an outpatient mycoplasma pneumonia, Haemophilus influenza, chlamydia pneumonia, and less commonly respiratory viruses. But just remember, pneumococcus, you need to cover for that. And in this sort of case scenario where he was an inpatient, then he actually ended up in the ICU, pneumococcus is again important. When they're more severely ill, you have to think of things like Legionella, so don't forget to get a urine antigen for Legionella. Aspiration could be an issue as well, depending on their comorbidities. So let's just say a few words then about pneumococcus. So this part of the talk, I'll be focusing a little bit on pneumococcus and influenza and why they go together, why it's important in the elderly that you actually see both of them. You see pneumococcus complicated influenza, just like we saw in this case. So it's a bacteria that has a polysaccharide capsule. And four-pointer, is there something over here that okay. Oopsie. Oh, there we go. Okay, so there is the sort of capsule. There are over 90 serotypes, and what's important that there's only a minority of those serotypes that are associated with the disease, and that immunologic protection is capsular serotype specific. So basically, you have to generate antibodies towards that capsule for protection. And this is just a summary slide generally about pneumococcal disease. So again, it's caused by the bacterium Streptococcus pneumonia, and you could think about a practical way of thinking about it is as invasive or non-invasive disease. So invasive disease just means that when you get one of these bacteria that are in a sterile site, normally it's the blood, it could also be the CSF, so that results in a bacteremia or sometimes in a meningitis. The most important mucosal or non-invasive cause in the elderly is by far pneumonia, but what happens often is we see these sort of combination syndromes where someone an elderly person gets a pneumonia with a bacteremia, or sometimes a pneumonia and a meningitis. So as I was mentioning this whole issue of the extremes of age, and this is a slide from the Centers for Disease Control looking at, they have a really extraordinary surveillance program, ABC Core surveillance for pneumococcal disease. So this is some of their data looking at, again, as I mentioned, very high attack rates in young children, and then it starts to creep up over the age of, particularly over the age of 65. And it's got really sort of a high, pneumococcus really has a high burden of illness among other bacterial infections, and I think a lot of that is driven by the morbidity and the mortality in the elderly. And this is a colleague of mine, Jeff Kwong, who basically said, he wanted to compare pneumococcus to other bacteria just to look at burden based on years of life lost due to premature mortality or reduced functioning and health-adjusted life year. And the sort of bottom line here is you could see that pneumococcus was #1. So really a very, very large burden of disease compared to other bacteria. So if we go back to this case, the organism that really made the person ill and go to the ICU was the pneumococcus, but there was a really important predisposing cause, and that was influenza. So I'll say a few words about influenza because it's really important in this age group. So it's a single-stranded RNA virus. There are 3 types of influenza, A, B, and C. A and B are really the more important ones for humans. It has 8 viral segments, so its genome is, as you can see here, segmented. And the subtypes of type A are determined by the hemagglutinin and the neuraminase. So these are things here. So the hemagglutinin is just a protein that sticks to the respiratory epithelium and just allows the virus to enter the cell and replicate. The neuraminase, which is this little red thing here, is just an enzyme that cleaves the virions. So these are the baby viruses that allow them to go and infect other respiratory epithelial cells. Okay, so it's really important. So we characterize influenza by the type of hemagglutinin and the type of neuraminase. And you're probably hearing about H7N9 in the news, right? So the reason why you can get these recombinations, these reassortant viruses, is because of the segmented genome. So, for example, the H7N9, which might not be, it's obviously of a public health importance in China, and it might make its way around the world. It has, potentially pandemic potential. We don't know yet, but it's because of the segmented genome that allows viruses, usually from aquatic birds, to recombine their genes. So if we look at influenza attack rates and complications by age, one of the best studies was done by Arnold Monto, who's a pretty famous epidemiologist for influenza, and he decided, like in the 70s and 80s, to study this entire township in Tecumseh, Michigan. So there's like 15 or 20,000 people, and he just sort of like swabbed and took blood from everybody and was able to figure out what the attack rates was. It was just a very good study. And this figure here shows just by age group. So you see that children have very high attack rates. And by age, the attack rates are sort of less variable. Children still have very high attack rates, but when you look at this figure here shows the hospitalizations, you see it's again at the extremes of age. It's the very young and the older people who are more likely to be hospitalized, and it is the older people who die from it. And excess influenza mortality rates by years have been, there's been exhaustive research looking at this, and this slide just summarizes the excess pneumonia and influenza mortality. They just go around together, and just you see these peaks at the pandemics, the Spanish flu, Asian and Hong Kong flu epidemic, just show this increased burden. And again, it's this combination of pneumococcus superinfecting influenza. Not all the time, but a lot of the time. So one important question is how influenza causes death. And again, this death is in the elderly. In seasonal influenza, most of the time, what we're talking about is this bacterial superinfection. So you get an influenza infection, or it could be another viral infection, and it's complicated by either pneumococcus or sometimes Staph aureus. Okay? Sometimes we'll see primary viral infection, and that's when the virus goes really crazy, replicating itself, and it creates this sort of cascade of cytokines, and it creates tissue damage, and that's really what's been seen in H5N1. Okay, we don't know in terms of H7 and 9. We don't really know that much about the pathology, whether there are superinfections. There was a report in the New England Journal a few weeks ago that suggested that some of those individuals who died from that virus were superinfected with a gram-negative bacteria called the Acinetobacter, but we don't know a lot about it. But even if we go back, let's say, to Spanish flu epidemic, where a lot of the people who were dying were actually a little younger, were in their early 20s, it was bacterial superinfection, not the sort of viral cascade that was causing death. So again, superinfection with pneumococcus and Staph aureus. And that's sort of one of the main take-home messages to you in terms of prevention. You should prevent influenza because it'll prevent morbidity and mortality due to this superinfection by pneumococcus. There are a number of mechanisms for this secondary bacterial infection that occurs in the elderly. I'm not going to go into that much detail, but there could be epithelial cell damage where the virus just screws up the respiratory epithelium and allows more attachment. There's changes in airway function, so elderly individuals who are infected with influenza will have more secretions, and their ciliary action will be reduced, and it provides a good sort of culture medium for bacteria to grow. There could be upregulation and exposure of receptors. We don't really know what the receptor is for pneumococcus, but that's a possibility. There's alternation of innate immunity. Toll-like receptors, TLR7 has been found, at least in mice models, to be important. And there's also effects on the virus from the bacterium. So the bacteria actually could produce enzymes that help cleave the hemagglutinin and helps the virus to replicate. Or the bacteria itself, cell wall components of that bacteria just are released and cause more inflammation. So there are a lot of common risk factors, when we look at influenza and pneumonia. So immunodeficiency, a whole bunch of medical comorbidities, which of course increase with aging. Residents in a nursing home or long-term care facility. So that's particularly important because that leads to these explosive outbreaks, right? As you know, residents of long-term care facilities They eat together, they hang around together, they, they do everything together. It's a cloistered environment, and there's obviously just, relatively small number of healthcare providers who, personal support workers who are there who can be infected and spread something like influenza. So it's lots of outbreaks in nursing homes, and of course age itself is an important risk factor. So one of the issues or questions is why is this? And there have been studies, I have to say, they're not always the greatest studies on immune senescence. There have been longitudinal studies of natural aging, Swedish studies, that have sort of looked at this concept of an immune risk phenotype, basically a CD4-CD8 ratio, this inverted CD4-CD8 ratio, which has been associated with increased death. Okay, so a number of studies have looked at mortality using this immune risk profile, and basically the idea again is that if you've got relatively few CD4, lots of CD8 cells, and so that ratio is less than 1, is associated with death. And there are a lot of mechanisms that are sort of proposed for this. So there could be just death of the CD4 cells, apoptosis, a reduction in the CD4 cells through apoptosis, and an increase or a reduction in the CD8 naive cells. So basically with your CD8 cells, you get fewer naive cells. So naive cells are good because they're poised to go and react to all these new antigens. But instead, in aging, you get these burnt out CD8. They're a subset of CD8 cells called CD28 negative cells, and they just accumulate, and they just can't respond very well to new pathogens. Okay, and it's thought that cytomegalovirus, which is sort of a virus that's sort of endogenous, it's latent, and just reactivates, and as you age, 80-90% of people over the age of 75 have antibodies against CMV. So the idea is that maybe your immune system is continually exposed to the CMV and sort of getting burnt out, trying to keep that CMV in check. And because of that, there's less reserve. So the problem with those studies is that they don't actually link it very well to clinical outcomes. Okay, some of them have linked it to mortality, but from an infectious disease point of view, they say, okay, let's compare young people to old people, and study after study, young people to old people, but with no infection phenotype, which is, the criticism I have. But it's a very interesting, important area. So let's talk a little bit now about prevention. Okay, so there's basically been two types of vaccines. There are two types of vaccines that protect people, particularly the elderly, and they're either polysaccharide or conjugate vaccine. So a conjugate vaccine is basically a little polysaccharide that's bonded to a protein. That's it. Okay. So if we look at the history of the vaccines, in '77 there was a 14-valent polysaccharide vaccine that was licensed. In 1983, the 23-valent polysaccharide vaccine was licensed, and that's what's in use today. That's the standard vaccine that's recommended. There was a conjugate vaccine licensed in the year 2000 in children. Okay, and that was a huge change because it really reduced the number of invasive cases in kids, and it had an indirect effect on adults. The 13-valent polysaccharide vaccine was licensed for kids in 2010. So that's basically saying, okay, let's slap on a few more serotypes here to get better coverage. And basically that same vaccine was licensed in 2011 in the United States, and in December of 2012, PCV13 was licensed for adults in Canada. And if we look at the sort of evidence for it, well, how good does the polysaccharide vaccine work? If you look at all comers, like older people who are healthy, those that have comorbidities, the whole shebang, it seems to have an effect on invasive pneumococcal disease, about a 75% risk reduction, which is pretty good. The problem is when you look at other outcomes for pneumonia, although this showed a slight effect of 30% risk reduction, you can see the I-squared is very high, 87%. So there's tons of heterogeneity, and they weren't really able to make any case for the effect of pneumonia. So there's really, at this point, there's no evidence that the polysaccharide vaccine prevents pneumonia. And when we look at people with chronic illness, There, it just goes down the tubes. Like you look at those effect sizes of 0.97 or going in the wrong direction, 1.56. There's no effect. So the bottom line is that the polysaccharide vaccine seems to have a response for invasive pneumococcal disease. That's pneumococcus that's going to be in your blood. It's probably okay, mainly more for healthy people. For people who have problems with their immune system, it's not so good. And this is a result of a Canadian meta-analysis, and what they found is they were like very rigorous. So they said, let's chuck out 2 of these studies we don't like. One where it wasn't really sure where people were randomized. The other, it wasn't sure that the outcome for invasive disease was really invasive. And the sort of the brown dots there show that their results showing really not much of an effect when you look at presumptive pneumococcal disease, pneumonia from all causes, or death from all causes. So in terms of just trying to compare and contrast these 2 vaccines, this is just a schematic to say, well, the polysaccharide vaccine, the way it works is activates your B cells, okay? So it produces a sort of IgM immune response, but not a very good IgG response, okay? And because it doesn't give you very much good memory in the B cells, you don't get a very good booster effect. Okay, so it's just sort of a transient IgM response. In contrast, remember I said that the conjugate vaccine has this little polysaccharide covalently bonded to this protein. Okay, that's important because T cells only respond to proteins. Okay, so that the dendritic cell, which is an antigen-presenting cell, will pick up the antigen from the vaccine, show it to a T cell, and there'll be a much more robust immune response involving your IgG antibodies and memory B cells. And because of that, you'll have later on a much better booster effect, so that if you need another vaccine, you'll respond very well. So that's the sort of major biological difference between the 2. And this is actually a slide showing what happened with a conjugate vaccine for PCV7. That's in children. You could see the red line is what's important, is that let's see if I could get the thing. Okay, the serotypes in that vaccine just went down. Invasive disease just went down. So it really changed the whole landscape of invasive pneumococcal disease. And it also had an effect. This is just vaccinating the children on the elderly. So you see that this is the effect on people over the age of 65. So even though kids were getting it, all these sort of bad pneumococcal serotypes were just not around anymore. So that had an effect of indirectly protecting the elderly. So the recommendations for use of the polysaccharide vaccine is for people who have like chronic lung disease, heart failure, over the age of 65, long-term care facilities, homeless IV drug abuse, chronic cerebral fluid leak, and chronic renal failure. So for your purposes, that is still the vaccine that's recommended, generally speaking, for people over the age of 65 and in long-term care facilities. There are new recommendations that came out 2 weeks ago for use of the conjugate vaccine in adults. So NACI, which is basically the Canadian organization that makes vaccine recommendations, said, well, it looks like a good vaccine, but we don't have all the evidence yet. So we're going to look through all the evidence and we're going to see where it should be used. And the bottom line is they thought that it should be used in people who are pretty immune suppressed. Okay, so people who have had a hematopoietic stem transplant, adults with HIV, and adults with various immunosuppressive conditions, so anatomic or functional asplenia, sickle cell disease, any sort of immune deficiency, including B-cell immunity, T-cell immunity, phagocytic function, if you have some patients on long-term steroids, okay, so that would be a good indication because they will not respond well to the polysaccharide vaccine. Patients who've been on chemotherapy, radiation therapy, post-organ transplant, and certain disease-modifying anti-rheumatic drugs. So anti-TNF inhibitors, for example. So any sort of anti-TNF inhibitor, let's say someone who has rheumatoid arthritis, where we would actually have to do a skin test to see, or were they previously exposed to TB, those people would be candidates for this type of conjugate vaccine. And when we look at the evidence for preventing influenza in the elderly, this is sort of a summary looking at, this is from a Cochrane review, and you can see when there's an outbreak and it's matched, that is when there's a good match between the antigens in the vaccine and what's circulating in the community, there's about a 60% risk reduction. And that's significant. When there's an outbreak and it's matched in an institution, you know, there's an effect size is in the right direction, but it's no longer significant, and things get a little worse in a non-outbreak matched institutional effect. So there is some effect of the vaccine in preventing influenza in the elderly, but it's not where it really should be. And in fact, there is a lot of, more recent, I guess, in the last couple of years, an idea that a lot of the efficacy of the influenza vaccine has been biased, has been really overestimated, okay? And this is a Cochrane review looking at the effect of the vaccine on, very specific outcomes like influenza, lab-confirmed influenza, and flu-like illness from, let's say, from RCTs, where you will have an effect, no effect on deaths from all cause from the RCTs. Okay. However, in contrast, when you look at the observational studies, all of a sudden, whoa, boy, look at this! It prevents death by about 50%. Right? This does not make sense. It has no effect. The observational studies show very little effect on flu-like illness, on influenza. Those are really responsive outcomes. But when you look at more generic stuff like death, it has an effect. So, people started saying, well, what's the deal with that? That doesn't make sense. The difference between randomized controlled trials and the cohort studies, these very specific outcomes, biologically important outcomes, in RCTs, there's an effect, no effect in deaths, but it's the opposite in the cohort studies. There must be some sort of bias. So Lisa Jackson in Seattle did this sort of comparison looking at the effect of exposure of influenza on all-cause mortality and pneumonia or influenza hospitalization. So she compared people who were exposed to the vaccine prior to the flu season. Okay, so no flu circulating, compared people who got the flu shot to those who didn't, and found that with no flu circulating, miraculously, it seemed to be preventing deaths, pneumonia, and influenza hospitalization. Okay, so obviously pretty good evidence for sort of a healthy person bias. Individuals are going to do better if we're getting selectively vaccinated. And when she looked at that, in a little bit more depth, trying to find out why that was, it just seemed like it was functional status that was the confounding issue. And then when she adjusted for confounding, a lot of that effect on death sort of dissipated. Okay, so that's just important to know. So we're at a stage where, influenza vaccine works for the elderly, but it's not so good. And so there have been a host of newer approaches to immunizing the elderly. Use of adjuvanted vaccines. That's when you use another sort of little chemical to try to improve the immune response. Intradermal vaccines, so when you go into deep into the skin to try to get a response. Higher doses, quadrivalent vaccines, and our studies have been trying to sort of immunize children to try to improve the effect in older adults. So the bottom line, there's a bunch of new approaches, and all of these vaccines, the problem is that they're all based on antibody studies, and there aren't very good head-to-head comparisons. Okay, so we don't really know which one is superior to the other. Now, how am I doing for time? How much time? 5 more minutes? Okay. So I'll just sort of wrap up just to give you, we talked about pneumococcus and influenza, and I'll just sort of give you, this is more updatey type of stuff. So if we go back to this case, this patient actually, a few months later developed a cellulitis, and social history is important because he's had a bunch of grandchildren and an infant, and basically there was a foreign body in his toe and plastic surgery took it out. He was treated with antibiotics, but an important thing is that he was given tetanus, diphtheria, acellular pertussis vaccine. Okay, so that's a relatively new recommendation that all adults who have not received TDAP as an adult should be getting it, and priority should be given given to those who have contact or anticipated contact with infants, parents, grandchildren, and child care providers. And basically the reason is because of pertussis. Okay, so to protect those infants, if there's basically waning immunity in adults with pertussis, so you want to boost their immunity so you could protect their infants. And slides of pertussis here, this is just the epidemiology of pertussis in Canada. And see, the problem with pertussis is that it's underreported in adults, particularly in the elderly, probably by about 100-fold. Okay, so there's a huge difference between what's reported in slides, to CDC and Health Canada, which is passive reporting, versus cohort studies where they actually really look at that. Okay, so those grandparents who are not, don't have immunity against pertussis might be infected. They have a cough. The doctor doesn't pick it up, and then they cough, or they kiss their infant, their grandchildren, or whatever, and then it could be a disaster. So that's a public health issue. So what other vaccines are important? Well, zoster, of course, is another one. So the zoster vaccine, it's the varicella zoster. The virus establishes permanent latent infection in dorsal root and cranial nerve ganglia, and years to decades later, it reactivates and can spread to the skin through peripheral nerve, causing a pretty nasty picture. And of course, the major complication is postherpetic neuralgia, which is just awful. So this is terrible condition, and the lifetime risk can be relatively high, up to 30%. And this is basically a famous slide by Pope Simpson looking at the age-specific epidemiology, and you see here that particularly over the age of 50, the risk goes up. Over the age of 60, it continues to climb, but the risk of postherpetic neuralgia goes up over the age of 60. So the bottom line is there's a large study of roughly 40,000 people in VA centers in the United States showed that the zoster vaccine decreased the incidence of zoster by 51%, decreased the incidence of postherpetic neuralgia by 67%. So huge burden, and in Canada this vaccine is recommended for those over the age of 60. At this time there was another randomized controlled trial showing a similar efficacy in people between the ages of 50 and 59. The real concern here is what is the duration of the protection. So if you immunize someone in their 50s, hoping to protect them for the rest of their life, don't know is the duration. We know the duration is at least like 5 to 7 years, but not sure if it goes much longer. So basically, this is the final slide. So take-home messages are that influenza and pneumococcus pose an important health risk in the elderly. Previous estimates of influenza efficacy have been exaggerated. There are new formulations that exist, which is good, but the problem is they're based on immunogenicity studies. We don't have actually clinical studies to show head-to-head comparisons. There are two choices of pneumococcal vaccine, the polysaccharide vaccine and the conjugate vaccine. The polysaccharide is the one that's recommended generally for healthy individuals. For those that are immunocompromised, the conjugate vaccine is the way to go. TDAP is recommended for adults in order to protect those who are at greatest risk for pertussis, and the zoster vaccine is recommended for those over the age of 60. That's it. Sure, yeah, I'd be glad to take any questions that there are any. Oh, yeah. It's recommended. Okay, so the recommendation is it's a CDC recommendation. So the Canadian, as far as I know, the Canadian recommendations are it still has to be revised, but it's recommended if someone hasn't received it, any adult over the age of 18. Yep.
In patients with anaphylactic reactions to A,
yep. Yeah, so basically that's a big change in terms of the what we do with egg allergies. So the way to think about egg allergies now, this was starting last year, was someone does not have a severe allergy, a mild allergy, they could actually get the vaccine. Okay? If they have a severe allergy to eggs, there's a way of actually giving it where you actually give a 2-dose step. You give like 10% of the dose the first time and then 90% afterwards. So more and more what we're advising right now is that egg allergy is not a contradiction. If someone has a very severe allergy, they could go to an allergist and they will use this sort of monitored approach to safely provide the influenza vaccine. That's a good question.
Thanks, Mark. Yeah, for that terrific state-of-the-art review.
And Dr. Gandell is a clinician teacher at Sunnybrook Health Sciences Centre and the University of Toronto. He completed his geriatric medicine training at the University of Toronto not too long ago in 2011. He has previous experience working in the community as a general internist, and his current interests include teaching and quality improvement. And he is going to give a presentation on being appropriate.
So thank you very much for the introduction and the invitation to talk. It's a pleasure to be here, and I will do my best to be appropriate. Title of my talk on being appropriate. I have no disclosures to report, and my objectives for the next short while after lunch, after the sleepiness sets in, are to review the concepts of polypharmacy and inappropriate prescribing in older adults, to review the tools available to enable appropriate prescribing and the outcomes observed by using these tools, and to consider other interventions to improve medication appropriateness. So, small outline. We'll review a medication list, go over a few definitions, review some epidemiology of appropriate medication prescribing, look at some outcomes associated with that, go over a few tools, which some of you may know, look at some other interventions to improve medication appropriateness, and offer a summary at the end. So just to start, a case with a little bit of history on a medication list to review. This is an 85-year-old gentleman with a history of dementia, hypertension, hypercholesterolemia, atrial fibrillation, chronic kidney disease, gastritis, gastroesophageal reflux disease, and a lumbar decompression surgery. And please take a minute to look at his medications. So memantine, digoxin, metoprolol, warfarin, glyburide, acetaminophen, etodolac, gabapentin, docusate, lactulose, iron, a multivitamin, omega-369 fatty acids. So absorb that if you can. We're not going to discuss the intricate or the details of each individual prescription, but please get a general overview of what he's taken. And I'd like you to write your answers down. I think most of you have pens at your table and a little bit of paper. So the first question I have for you, to keep you awake and alert after lunch, is does this man have polypharmacy? I'd like you to write that down. And if yes, please write your definition. And I should say one of my other objectives of this talk was to prepare you. I know many of you will be writing a subspecialty exam soon, and some of you will be writing in several more months, or a general exam or a subspecialty. So the other unwritten objective is to prepare you somewhat for those exams. So list 5 evidence-based tools that could assist you in your determination. And I see some crowds. And list 3 outcomes associated with better medication prescribing. I don't see everybody's pens moving. I'd like to see more pens moving and more ink on paper. And please look at your answers as I go through the rest of the slides. Okay. Everybody, do I have the signal to move on? So we'll start with the multiple choice question after you've indicated your answer. Regarding polypharmacy, which one is true? A, consensus guidelines have established greater than 5 medications as a working definition of polypharmacy. B, 40% of community-dwelling older adults take at least one potentially inappropriate medication. C, inappropriate medications have been associated with hard outcomes such as mortality. Or D, errors of omission increase as the total number of medications taken increases. I'm not going to give you the answer immediately. Just keep your answer on your paper to yourself. So before we get into being inappropriate, so again, on being appropriate, the ideal regarding prescribing. When you're prescribing or ordering a drug, you want to have a clear scientific evidence-based indication for each medication. You'd like the medication to be well tolerated in the majority of patients. You'd like the medication to be cost-effective, and you'd like it to align with patients' values. And to follow up on a talk earlier today, you also want it to be free of drug-drug interactions and perhaps drug-disease interactions. So that is the ideal, and we hope that, I'm not sure if the medication list we reviewed meets that ideal, but that is what we strive for. So the challenges to prescribe the appropriate medication list, there's often in the patients that we see an absence of clear scientific evidence, and there's a few reasons for that. Older adults are often excluded from randomized controlled trials, and the estimate is that only about 25% of RCTs include patients in our demographic. And if you've reviewed an RCT and looked at the table 1, there are a few questions to ask when you look at the table 1. You want to see if the randomization was balanced. Then you want to determine who is this patient, and you also want to determine whether this patient is like mine. And many times, your patient that you're faced with in the office doesn't meet the average participant in the table 1 of the RCT that you're considering using as the scientific basis for your decision to prescribe that drug. And also, as you learned this morning, changes to pharmacokinetics and pharmacodynamics alter the tolerability of those drugs at usual doses, and often with changes to life expectancy, patients' values may change. So a definition of polypharmacy, you can look at what you've written. This is one definition. The prescription, administration, or use of more medications than are clinically indicated. And often it is assumed to be present when a threshold number of medications are taken. And generally that's 5 to 10. The problem with that definition is there is no consensus, and there is no consensus guideline that that is the absolute number. It also doesn't really account for which medications to prioritize. So if you have too many medications, which ones are you going to focus on, and which ones are you going to say are not that important? It also doesn't address errors of omission. So if you have a clear scientific evidence-based reason to be on a drug, polypharmacy as a term doesn't really capture the ones that are missing. And often it's a challenge to categorize over-the-counter preparations, herbal remedies, or eye drops. So inappropriate prescribing is probably a more appropriate term for this syndrome. And that takes into account a number of factors, and those are misprescribing, overprescribing, underprescribing, patient values, and cost. And generally, you fall into a problem of misprescribing when the dose, route, frequency, or duration is not appropriate, when you have drug-drug interactions, as you heard this morning, or drug-disease interactions, or overprescribing when you don't necessarily have a clear indication for the use, but it's prescribed anyway, or underprescribing if you do have a clear indication for the drug's use and you miss it, and patients' values and cost. So what is the prevalence in your patients that you see in the office of inappropriate medications? So this was taken in the late 90s. I'm not sure if the reference comes out. It doesn't come out on my screen, but it does on yours. So about 20% of community-dwelling older adults take at least one potentially inappropriate medication. That's a little bit lower than the estimate I gave you in the multiple choice question. And the risk is often increased with the more medications you take. And in this cohort, at least, the risk was increased with worse health or self-reported poor health. So if you have an older individual who takes greater than 5 medications, in 65% of those people, there's generally at least one, that's potentially inappropriate. In that same subset, not just generally community-dwelling older adults, but specifically people who are taking greater than 5, 64% are missing one that's necessarily indicated. 42% have both one that isn't indicated and are missing one that is indicated, and 13% hit it just right. So inappropriate medication use increased with the total number of medications taken, but underuse remains constant. So I mentioned in the outlines too that we wanted to talk about some of the outcomes, and some of your exam questions will focus on the significance of this problem. So we know the magnitude of the problem, but why do we care in a way? And so this is an example of misprescribing, or the risk of being hospitalized 1 week following prescription of a known drug-drug interaction. And perhaps you saw this slide this morning, maybe or maybe not. This is research out of Sunnybrook or Toronto. And essentially, if you are on glyburide and you were given an antibiotic potentially for a urinary tract infection, cotrimoxazole, your risk of being admitted a week later with hypoglycemia was 6.6 times greater than if you didn't get that medication. And so that's potentially a preventable adverse drug event. Hyperkalemia, if you're on an ACE inhibitor and you got a potassium-sparing diuretic 1 week prior, your risk of admission was 20 times greater. Digoxin toxicity, if you were given clarithromycin for something like a respiratory tract infection, your odds ratio was 11 or 12 times greater to be admitted. So that's hospitalization with drug-drug interactions or misprescribing. What about outcomes with simply inappropriate medications that don't necessarily interact with other drugs? So the risk of hospitalization simply being on potentially inappropriate medications is almost 3 times as high in community-dwelling older adults, almost 1.5 times in long-term care, and it's also been associated with mortality. And we'll review the criteria they use to determine whether or not the medications were appropriate or not. But there are cohorts that have associated simply being on inappropriate medications with an increased risk of death. So regarding polypharmacy, which one is true? Think back to the answer that you chose. The correct answer is C. Inappropriate medications have been associated with hard outcomes such as mortality. Errors of omission remain constant as the total number of medications taken increase. Errors of commission increase. Consensus guidelines have not established that greater than 5 medications is a working definition of polypharmacy, and appropriate prescribing is a better or a more meaningful term. And 40% of community-dwelling older adults, that estimate is a little bit high. It's really about 20%. So how do we do this better? Striving for better. So regarding medication appropriateness tools, which one is false? A, explicit criteria perform better than implicit criteria in identifying inappropriate medications. B, the most recent revision of the Beers criteria now include recommendations for errors of omission. C, the stock criteria have been compared to the Beers criteria. Any knowing looks? Maybe? And D, the START criteria have identified statins as the most underprescribed medications in older adults. So regarding medication appropriateness tools, which is false? Oh, I have some enthusiasm now. That's good. That's very nice. So medication appropriateness, the tools, and these are your 5 tools. These are the 5 evidence-based tools that you can consider. There are explicit criteria and implicit criteria. Explicit criteria simply means that it's a list of medications that have been itemized for you to refer to and compare to the list that your patient is on. Implicit criteria seeks to ask a number of questions to determine whether or not the medication you're taking is appropriate or not. And that's often what you do in clinic when you're reviewing a case. You go through, is there an indication? Is there a drug-drug interaction? Is there a drug-disease interaction? Is the dosing appropriate, et cetera, et cetera. So the explicit criteria, you have your Beers, the improved prescribing and the elderly tool. That one may be unfamiliar to you. The screening tool of older persons' potentially inappropriate prescriptions, or the STOP tool, and the screening tool to alert doctors to the right treatment, the START, which was designed to be used in conjunction with the STOP tool, and it covers errors of omission. And implicit criteria for the medication appropriateness index, which is most often used in research settings to determine or to measure change in appropriateness of medication lists. So explicit criteria, we'll look at some of these. So the Beers criteria. They were the first set that was published in 1991. It was updated in 2003 and 2012. It's an expert consensus list, and they're presented by drug class. So they're presented by anticholinergic or psychotropic medications or cardiovascular antidepressants. They're presented by class. And they're also categorized in medications to avoid absolutely. So medications that are a hard stop, you do not prescribe them in patients over 65 years of age, and to avoid in patients with specific diagnoses such as NSAIDs in congestive heart failure and hypertension. So that is absolute hard stop. And there's also now a category for medications to be used with caution. So they may be appropriate in certain circumstances, and they give you a rationale, a recommendation, the quality of the evidence, and the strength of their recommendation. So this is an example. This is the table of medications to be used with caution in patients who are over 65. And it's a little bit busy. So I've added a chart to clarify for you, and perhaps we'll look at the first one just to review it to see whether or not you like using the Beers criteria or you think this would be useful for you. So the drug is aspirin. We're all familiar with aspirin. So primary prevention of cardiac events. So they say this is a medication to be used with caution in primary prevention of cardiac events. The rationale is that there's lack of evidence of benefit versus risk in individuals greater than 80. The recommendation is used with caution. The quality of the evidence is low, and the strength of the recommendation is weak. And you can think to yourself whether or not that fits with the practice that you're currently, with your current practice. Dabigatran is also listed there. For the sake of time, we won't cover that. So that is how it's presented. So a few of the limitations for the Beers criteria: errors of omission have not been added in 2012. There are no randomized controlled trial outcome data to support its use. There's cohort data. There's no RCT evidence to say that using this tool improves patient outcomes. And the reason I highlight this is the STOP tool that we'll see in a minute. The creators of that tool have been much more aggressive in trying to determine and prove that their tool is better than the Beers. And they're organizing trials to determine that. So it has a need to be revised and updated in time, as you saw, 9103, 2012. It doesn't really take into account drug-drug interactions, and perhaps some of you have applications or apps on your smartphones to do that easily, and it doesn't take into account patient preferences. So I put this one up. I'll cover it quickly because this is the Beers criteria is American. This tool, the Improved Prescribing and the Elderly tool, is Canadian. It was created in Western Ontario by, Dr. Nagler, but Dr. Chris Breimer, who some of you may know was intimate or very involved in this tool. So instead of an American panel, it was a Canadian panel of experts that got together and created a list of drugs that were inappropriate. And this tool was created based on the 14 most frequent inappropriate medications that were detected on admission to hospital or a geriatric assessment unit. And I'll show you the tool. That's it. And the difficulty with this tool is that it was developed in the late 1990s and has not been updated. So the recommendations right now are out of date. And one of the top recommendations is to avoid beta blockers in congestive heart failure, which we now know is not the right thing to do. And there's no patient outcome data for the IPET as well. So that's that tool to know. There's an American version. The Canadians, we have a tool as well, although it's out of date, and perhaps as a research project, you may want to update this tool in your training. So moving on, the screening tool of older persons' potentially inappropriate prescriptions, or the STOP criteria. This was developed in the United Kingdom, in Ireland, in 2008. And this is a list of 65 different medications, or some of the same medications, but to avoid in different indications, for potentially inappropriate prescribing in older people. And it's presented by physiologic system. It's not presented by drug class. It's been shown to have good inter-rater reliability, and it takes into account drug-disease interactions. Duplicate drug class section is addressed, and there's a section now for patients at risk for falls and what medications to look at for patient at risk for falls. This is it. Sorry, another busy slide, but I've helped a little bit. And this is recommendation 13. And you remember the Beers criteria, the medications to use with caution. I showed you aspirin. This is the STOP tool's articulation of how to avoid aspirin, and you can determine which one you like better. So aspirin with no history of coronary, cerebral, or peripheral arterial symptoms or occlusive arterial event, not indicated. So aspirin for primary prevention, not indicated. Depends which tool you prefer. The START tool, screening tool to alert doctors to the right treatment, 22 START criteria. It's a complement to the STOP criteria to capture errors of omission, and it's also prescribed by physiologic system. And it's for use when no contraindication to a prescription exists and functional status and life expectancy justifies the prescription. And that last feature is open to interpretation and judgment. And so those are the 22 criteria. If you read them and you look over them, you'll see. I made it a little bit easier as well. These are some of the recommendations. So in the cardiovascular system, statins. Statin therapy in patients with documented history of coronary, cerebral, or peripheral vascular disease, where the patient's functional status remains independent for ADLs and life expectancy is more than 5 years. So people often omit statins. It's an indicated drug for secondary prevention of cardiovascular outcomes. And at least in the START criteria, they articulate the functional status is independent in ADLs and life expectancy of 5 years. I'm not sure if that's how you're applying your use of statins to the patients you see in clinic. You may want to use this as a comparator. They also have statin therapy in diabetes mellitus if fasting serum cholesterol is greater than 5 or additional cardiovascular risk factors present. So the START criteria has been tested in a cohort of consecutive patients admitted to a teaching hospital. And according to their 22 criteria, almost 60% of patients presenting have at least one or more than one prescribing omission. And the one that's of greatest frequency was statins in atherosclerotic disease, 26%. Warfarin in AFib, 10%. Aspirin in arterial disease, 7%. Calcium and vitamin D supplementation in osteoporosis. So a little bit, I said stop the beers. So again, this is because the creators or the developers of the STOP criteria want to prove in a way that it's better than the Beers criteria. And so these are two studies that show that the STOP criteria is more sensitive at picking up potentially inappropriate medication than the Beers criteria. And the likelihood of a serious avoidable adverse drug event, so that's not just being an inappropriate medication, but that's an outcome associated with inappropriate medications, that the tool is better at detecting the drugs that are going to lead to bad outcomes as well. So moving on to implicit criteria, remember these are questions you can ask, they're not just a list of medications. So the Medication Appropriateness Index, or the MAI, 10 questions to determine whether the drug you want to use is appropriate or not. And the responses are weighted from 0 to 3 to get a scale or a cumulative score. The difficulty with this, if you apply the STOP, the START, and the Beers criteria, you don't need to know a lot about the patient or exercise a lot of clinical judgment. You just need to follow the rule. In this case, you need to know a lot about the patient and the medication to answer the questions. So the advantages, though, of this are that it does not need to be updated. Drug-drug interactions are taken into account, drug-disease interactions as well. The disadvantages are it doesn't cover the errors of omission as well. And there it is. This is the tool. So you can look at some of the questions. It's hard for me to see, but is there an indication for the drug? Is the medication effective for the condition? Is the dosage correct? Are the directions correct? Are the directions practical? So are you dosing it at 10 p.m. when the patient is, you're waking the patient up to administer the dose? Are there clinically significant drug-drug interactions, drug-disease interactions? Is there unnecessary duplication with other drugs? Is the duration of therapy acceptable? And is there a lower cost alternative available? And so you count up the score. And if you score 3 on any one of these 10 questions, then the drug is deemed to be inappropriate. So this is more for a research tool. You can measure changes on overall appropriateness. So back to the question regarding medication appropriateness tools, which is false. I made it a little different, so there are 2 that are actually false. So explicit criteria perform better than implicit criteria in identifying inappropriate medications. They've never been compared. The most recent revision of the Beers criteria now include recommendations for errors of omission. That's not true. They don't. The stop criteria have been compared to the Beers criteria. They have. And the start criteria have identified statins as one of the most underprescribed medications in older adults. That is true for secondary prevention. So a little bit of a mental break here. I need to get my cursor. There we go. So U of T residents, if you've heard this song before, please let the others have a chance to answer.
Kids are different today. I hear every mother say, mother needs something today to calm her down. And though she's not really ill, there's a little yellow pill. She goes running for the shelter of her mother.
Doctor, please, some more of these. So you often get your patients at the door requesting more of these medications or do anything but stop them. Outside the door, she took 4 more. So anybody? The name of the tune? So it's a Rolling Stones song. Hint. So it's called Mother's Little Helper. And it's an ode. It's the only song I know that's been written specifically for benzodiazepines, or for any drug, for any drug of that matter. So if you know another song, please tell me. If you know a song that's written specifically for a drug or a drug class, I'd like to know. But essentially, it's a nice song, and it captures a little bit of the anxiety. And it was written in the early 60s, so it's nice to know that the predicament has changed right when the medications were synthesized, but the predicament has changed in a sense that there's some I guess, cultural era qualities of the song that I'm not commenting on, but otherwise the medication is, you feel it. You feel it in clinic when they want those benzodiazepines. So other interventions to reduce inappropriate medications, it's not all about the tools. What you have been doing is good, and I'll show you that in a minute. So pharmacist-led interventions, CGA, and computerized support systems. So this is one randomized controlled trial and one or 2 systematic reviews that show pharmacists are a good thing. Having pharmacists look and review medication in the setting of a multidisciplinary team improves medication appropriateness based on the MAI that's sustained at 12 months. Unfortunately, this randomized controlled trial did not reveal a difference in hard outcomes such as adverse drug events, hospitalization, or mortality, but it did improve the appropriateness of medication use. And 2 systematic reviews on pharmacists and clinical roles reviewing medications, 36 studies in 7 out of 11 where appropriateness was measured, it improved. And their bottom line was that pharmacotherapy of elders improved when pharmacists were involved in education of other healthcare professionals as part of a multidisciplinary team. So what about what you do? Comprehensive geriatric assessment. Are there any outcomes or improved appropriateness of medications with that? Yes, multidisciplinary team review. This was a secondary study of whether or not CGA improves other outcomes, but it was a randomized controlled trial, 11 veterans hospitals in the States, 900 patients over 12 months, and according to the Beers criteria and the medication appropriateness index, comprehensive geriatric assessment did improve the appropriateness of medications. And the second trial there is geriatric outreach. So an outreach team, which you may have been involved with, if that included medication review, outreach teams did show a decrease in the appropriateness index score. The last thing is computer support systems. So I showed you the outcome or the risk of hospitalization with drug-drug interactions. So if you had a computerized physician order entry system with clinical decision support that alerted you, oh, the patient is on glyburide, don't take the antibiotic that's going to promote hypoglycemia. Unfortunately, this was published in JAGS. Unfortunately, this trial, 29 long-term care units that were cluster randomized to a CPOE with decision support or without decision support did not make a difference in adverse drug events or preventable adverse drug events. And these authors, I think, were quite ambitious. They didn't simply strive for medication appropriateness, they were striving for outcome. And the reasons they gave that the decision support did not work, it was not integrated well enough with the patient's clinical status. So it could not alert you well enough to the comorbidities that the patient had and their lab values. And so they had a lot of alerts coming up that were very, very sensitive, but not very significant. And so those alerts ended up being ignored, unfortunately. And there's a systematic review as well that 8 out of 10 revealed modest improvements in appropriate prescribing. 2 out of 10 reported clinical outcomes, but were mixed, and one of those is the trial that you see up above. So now that the list is appropriate, so if you did all those things and you have the appropriate list, what is the last thing we need to make sure that the patient is achieving the outcome that we desire? What's the last piece of all of this?
Education.
So education, but you're educating them towards what?
Make the changes based on.
Okay, so then what do they have to do?
Adherence.
Excellent. So medication adherence, adherence versus compliance. Compliance is a term that's less often used in the literature because it has paternalistic overtones, so they're trying to stick to adherence. The prevalence of non-adherence in the elderly runs as high as 75%, and it correlates with the total number of medications taken. And perhaps when people use the term polypharmacy, that's one of the things that they're implying is they're not going to adhere, perhaps. And generally, it's thought that you need to adhere to about 80% of your medication threshold in order to achieve the outcomes that the medication was designed to provide. And low adherence is associated with bad outcomes. There's data to show that if you adhere less to your medications, your risk of dying is higher. So factors that affect adherence, comprehension of therapy, adverse, irrespective of your cognitive status. So I appreciate your comment. I'm sorry, in green. So education is important. So irrespective of cognitive status, they need to understand why they're taking the medication. Adverse effects, medication costs, regimen, complexity, cognition, and mood. And this was a Cochrane review or systematic review of interventions to improve medication adherence in older adults, so specifically in the patients that you see. And 36 out of the 83 interventions revealed improved adherence, not necessarily clinical outcomes, but improved adherence. And for them to be effective for long-term treatments, I've listed the interventions there. Typically, most trials were done to incorporate more than one measure or more than one intervention to improve adherence. So it was education along with more regular follow-up, or education with a blister pack and a dosette, or education with a caregiver supervision of the medications. So a summary, medication appropriateness is a more meaningful term than polypharmacy. The 5 evidence-based tools to assist you in determining appropriate medication or the appropriateness of the medication are the BEERS, the Stop and Start tool, the IPET, and the MAI. And pharmacist participation, CGA, and CPOE with decision support have been shown to improve medication appropriateness in older adults. And that's it. Any questions?
Where a person on a medication may get a side effect, and instead of dropping that medication, they treat the side effect with another medication.
So specifically for the cascade, no, I'm not aware of that. But if you use these tools, if you're evaluating a patient for CGA and you use these tools, So let's say the MAI, Medication Appropriateness Index, they'll say, is there a clear indication for this drug? And then it's up to you to do a little bit of sleuth work to say, this is a disease condition, this medication is not appropriate for that disease condition. So perhaps I was expecting one question is, does anybody use these tools on a regular basis? So I think one of the problems with the tools is it's nice to read them to become familiar with the suggestions, but they're not really organized or created in a way that makes it easy to have it in the office to say, this is my patient, and I'm going to look through 65 recommendations at the point of care to do that. And so hopefully in time with information technology, and if it's better integrated with the clinical status of the patient, then these tools will be more available at point of care than I think now most of them have more of an educational focus to them. Thank you.